Welcome to the Symposium on Response to the COVID-19 Pandemic, Lessons Learned. This is a very important symposium and a discussion considering the current situation where Sri Lanka and the whole world is facing. And today, we have a very eminent panel of resource persons lined up representing Sri Lanka, United Kingdom, USA, and Singapore. And these speakers will be sharing their experiences and the lessons learned based on the country experience. First, we'll be starting the host country, Sri Lanka, and our resource person is Dr. Nihal Abeysinghe, who is a very experienced epidemiologist and currently the consultant epidemiologist and the deputy director of the IRD for health and social care. And he'll be discussing the Sri Lankan experience of COVID-19. Over to you, Dr. Abeysinghe.
Good morning. Thank you very much for invitation to this panel discussion. And I thank the President and the Council of the SLMA for the invitation, the Government of Sri Lanka, Director General of Health Services and all in the health sector, all armed forces and police personnel, those who are responsible for control of COVID-19 in Sri Lanka. So let me begin my technical presentation today. So I will begin with this presentation from the lessons learned from the global response for SARS in 2002 and 2003. You could see that, so these were the lessons that we learned from the SARS epidemic in that era, and highest political commitment is required between WHO and countries with the public and the media. Multi-sector approach is needed. It could be health, veterinary, food safety, economy, transport, and many other areas. So, and it has to be evidence-based action and transparency in taking action and the confidence of the governments and the health teams. So the second one is that efficient alert and response system in all countries to face similar epidemics and rapid sharing of data and information. So the global partnership also very important, and there were no borders in epidemics. No country can do it alone, and global resources need for rapid control, who has a unique role. WHO has the unique role which should be technical, neutral partnerships with countries. So these were the lessons that we learned from 2002-2003 SARS epidemic. And if we go directly into the novel coronavirus outbreak, this time the timeline of early stages of this epidemic, you could remember that on the 30th of December, a cluster of cases of pneumonia of unknown origin reported in Wuhan to China National Health Commission. And then on the 1st of January, human seafood wholesale market was closed in Wuhan. And on the 7th of January, novel coronavirus was isolated. And on the 11th, the first fatal case was reported. And on the 12th, the whole genome sequence shared with WHO and public, virus designated 2019 novel coronavirus. And then on the 13th of January, the first case reported from Thailand, that's outside of China. On 16th of January, the first case reported in Japan, so that is close to China, but still outside. And on 19th January, first case reported in Republic of Korea, 2 cases in Beijing, and 1 case in Guangdong. And on the 20th of January, first reports of infection in healthcare workers caring for patients with 2019 novel coronavirus. And on 24th, by 24th, 835 cases reported in China, 549 from Hubei province, further cases reported from all but 1 province. So this was the story up to 24th, and the World Health Organization declared a global pandemic of novel coronavirus and then named this as COVID-19. So all countries were expected to increase capacity to detect and care for patients, ensure hospitals have the necessary staff, supplies, structure, and the system, develop life-saving medical interventions, take all necessary measures to slow further spread, avoid health systems becoming overwhelmed, prevent infection among risk persons, including elderly and persons with comorbidities who are at high risk for severe outcomes, including deaths. So all this information was available in the WHO website and many other websites, and all countries were expected to take these appropriate actions. The global strategic objectives were to mobilize all sectors and communities to take ownership of and participate in the response and in preventing cases through hand hygiene, respiratory etiquette, and individual level physical distancing. Control sporadic cases and clusters and prevent community transmission by finding and isolating all cases, appropriate care and tracing contacts, quarantine and supporting all contacts. Suppress community transmission through context-appropriate infection prevention and control measures, population-level physical distancing measures, and appropriate and proportionate restrictions on non-essential domestic and international travel. And reduce mortality by providing appropriate clinical care for those affected by COVID-19, ensuring the continuity of essential health and social services, and protecting frontline workers and vulnerable population. And we knew that no one size fits, and it was expected that each country to assess its risk and rapidly implement the necessary measures at the appropriate scale to reduce both COVID-19 transmission and economic, public, and social impacts. WHO defined 4 transmission scenarios for COVID-19. Number 1, no cases, countries, territories, areas with no cases. That's the first category. The second category was sporadic cases, countries, territories, areas with 1 or more cases, imported or locally detected. So this scenario that WHO was discussing, because WHO expected that all countries to have restrictions on the incoming travel, and all countries to introduce screening at the airports and the seaports. So that's why this category was identified as sporadic cases, but Sri Lanka did not have this phase because we had an influx of infected patients from other countries, so therefore that we straight away went to cluster of cases. So in the case of cluster of cases, it's countries, territories, areas experience cases, clustered in time, geographic location, and or by common exposure. Community transmission, countries, territories, areas experiencing large outbreaks of local transmission. So far, Sri Lanka has not seen any community transmission. So this is defined through an assessment of factors, including but not limited to large number of cases, not linkable. This community transmission is defined as large number of cases not linkable to transmission chains, large number of cases from sentinel lab surveillance, or increasing positive tests through sentinel samples, and routine systematic testing of respiratory samples from established laboratories, and multiple unrelated clusters in several areas of the country, territory, or area. So this was the Sri Lankan picture, and you could easily see that we had 3 very important clusters over the months. The first cluster was because of the influx of infected persons to the country. And the second was a cluster that was occurred in the Navy camp at Valisara. And the third cluster at Kandakadu, rehabilitation center for drug addicts. So these were the 3 clusters, and we knew from the very beginning that COVID-19 will be a person-to-person transmission epidemic. So it is expected that we need to protect vulnerable groups, and then to make sure that the virus will not get into the vulnerable groups. But at least in these 2 instances, in the Velisara camp and the Kandakadu camp, we missed that opportunity. So Sri Lankan approach, I would say that the preparedness was the key, and the response between 30th January, when the WHO declared that there will be a global pandemic of COVID-19 or novel coronavirus, and up to the time 11th March was very poor, I said. And then we went into many actions, but then I will come later. And the first time in the history that we politicized public health response to an epidemic. So this was basically that the mistake that we were doing during this period, but we paid huge cost for the delay in responding. The crisis management would have been multi-sectoral, and the non-governmental organization, private sector, and others, and multi-level, and we did not see any efforts to decentralize the response. However, we managed very well from the 20th March during the curfew period, but there was several obvious shortcomings. As I said earlier, the outbreak in the Navy camp and the outbreak in Kandakadu, the rehabilitation center. So lockdown from 20th March was very effective in preventing the movements of the people. And Sri Lanka do have a very high literacy rate, so that basically supported our control activities. And the public health system that we do have a very good public health system. Our MOH, medical officers of health, and public health inspectors, and the armed services, they did very well during this period in tracing those who were exposed and the contacts. And also that if we go back to the SARS epidemic experience, that the temperature and humidity also played a fairly well role in controlling the epidemic in this country. So it should have been a massive operation to protect the nation. Could have been a coordinated response. In epidemiology, we have a very good epidemiology unit, and we have a epidemiologic surveillance mechanism and strong epidemiology service in the country. All vaccine preventable disease, including measles, have been eliminated, at least endogenous measles in the country. And we have controlled Japanese encephalitis, malaria, and filariasis, all mosquito. So therefore, that actually we had a very good base to start, and these were the expected activities in control of COVID, like testing, detecting, suspecting, and quarantine, engaging and empowering people. And so these are really the minimizing the movements of the people. People always wanted to know that government has a plan and reasons for taking different measures, convincing public to practice the new normal life, and so physical distancing, why, and hand washing, why, wearing a mask, why. Sound plans to detect, isolate, test, treat patients, proper plan for quarantine the suspected contacts, protecting staff of hospitals and laboratories, engage public support, and ensure smooth running of essential services. So we need to do a lot of things that before releasing the grip, and the regular review of the situation, and a plan to control disease transmission, and plan to recognize early the risk of and manage it, and sensitize the public what the government expects, what the government will do, and what the individual families do. So this type of plan should be there before we release the grips. And it's a challenge to the government, a social contract, what risk we can accept, what risk we can manage, what we can reduce in our daily activities. So carefully discussed process would need for ending this COVID-19 outbreak. So it is same intelligence, verification, response, and follow-up. So a lot of people to contribute to this control of outbreak in the epidemic in the country. And I am sure that Sri Lanka will be setting an example to the world for COVID control. Thank you very much.
Thank you, Dr. Abeysinghe, for that very analytical and insightful overview of the Sri Lankan situation. Our next speaker will be introduced by my co-chairperson, Dr. Olivia Corazon Nivares. Over to you, Olivia.
Our next speaker is Professor Zafar Iqbal. He is a visiting professor of Staffordshire University and Associate Medical Director, Public Health, MPFT. He is also a member of the FPH Global Health Committee and founding board member of the Center for Health and Development based in Staffordshire University. Over to you, Professor Zafar Iqbal.
Hello, can you hear me?
Yes.
We can hear
Are
you.
you able to hear me?
Yes, we can hear you.
Loud and clear.
Okay, that's fantastic. Thank you very much. It's a great privilege to be invited to one of the oldest and greatest medical societies in the world, and I know a little bit about Sri Lanka from my experience of working with Sri Lankan colleagues, and I had the pleasure of listening to Dr. Swee Alves about the ancient history of Sri Lanka a while back. But today I'm going to give you the UK story on how UK has handled the COVID crisis. I'd just like to declare that I don't work for the UK government. I'm a local consultant public health practitioner, so I can give you my own personal kind of perspective on this. So I'm not representing the UK government here. So if I can share my slides with you, can you see those slides? Are you able to see those?
Not yet.
Not yet. Hold on a second. Let me just see. Let me just see whether I need to share the screen. Is that? Can you see that?
Yes, we can.
Okay, that's great. Let me just go with.
Slideshow view, please. Yes.
Yeah, I can go on a slideshow as well. That's fine.
That's great.
So can you see that now?
Yes, perfect.
That's fantastic. Okay. Well, I won't dwell too much on the epidemiology of COVID, because I think Dr. Nihal Abeysinghe is quite kind of nicely described the kind of global situation and how it all kind of started. But I'll touch upon the UK experience in terms of the health service, the preventative measures, the social measures, and the economic impact and the lesson. I mean, perhaps, we could focus on the lessons learned. I think that's the really key issue, that we learn from each other's experiences. So, I mean, to start with, when back in January, March, when we started to see the cases, and it's clearly a very nasty illness with a 50% mortality, certainly at the outset, within the intensive care units. And it was a shock to the UK kind of health system when we started to get these large number of deaths. So COVID, as Dr. Nihal has explained, has got many impacts. It's got the direct impacts, but also many indirect impacts on people who don't have COVID, and whether they've cardiovascular disease, whether they have cancer, mental health. and there's enormous social and economic consequences of the illness. So this is just the sort of global epidemiology. When we started, Europe became the epicenter after China, and with the United States, and now it shifted over to South America, where South America is the epicenter. We're still getting problems in the USA, but we'll hear more about that. But also now we're getting more widespread cases in India, Pakistan, and also Africa as well. So this is the UK timeline, and it's really sort of March when we started to get a number of cases. And we initially had 2 cases in kind of January, but then by March we had 1,000 cases. And the whole country was in shock, really, when it saw these pictures of people dying within Italy and Spain, and they couldn't even get admitted to hospital because the hospitals were running out of space. And that really shocked the whole government, the whole system into kind of action. And March 23rd was a key date when the Prime Minister introduced a series of measures. And I'll come back to the timing of that and sort of what my opinion was about that a bit later on. So this is our epidemic curve. It's very different from Sri Lanka, as you can see. Our peak was around about mid-April, and it's been declining ever since then. And this is the mortality rate. The data from the hospital is very similar. It follows the same epidemic curve, again showing a peak in kind of April, and also the curve regarding the use of ventilators, which is absolutely critical, is also very similar. We've obviously had a large number of deaths, and it's arguable how many deaths we've had because there's some controversy over how we measure deaths. But we've had just under 50,000 deaths, and it's no different from other places where we found very high death rate among older population. Excess mortality is really important. I know this is a complicated slide, and there's a big variation between the experience of different countries. Certainly within the UK, we've found that we've had a large number of excess deaths in terms of what we would normally expect. And perhaps up to about 50% excess deaths. And when you compare with Europe, it's actually, quite, you can see that we've got quite high numbers of excess deaths. And again, there's controversy on how you measure this. So in terms of the mortality picture, we've had a pretty bad experience. And as Dr. Nihal explained, the overall philosophy is very similar to, as the global health, as kind of WHO have kind of proposed, is essentially to, when we're in the shock phase of it, acute phase of it, we had to stabilize our essential sectors, the health service, the care system, and really define everyone into essential workforce and non-essential workforce. And it was a question of the non-essential workforce supporting the essential workforce, and then introducing social and economic measures, and then slowly relaxing these measures. So, I mean, this is the kind of fundamentals of pandemic resilience. And again, this kind of shows the same kind of issue pictorially, and the various social measures that have been undertaken. I mean, certainly when initially the social measures were taken, it was a real shock to the system. People weren't allowed to go out unless for absolutely essential reasons, such as getting food. They weren't allowed to visit anyone. You couldn't allow to go and see your parents, it was just it was really total lockdown, and with closure of businesses. And over a period of time, a lot of those measures have been relaxed. Testing has been very controversial within the UK, and And there's different aspects, dimensions to testing. There's you can't test everyone. Once you've got large numbers of cases, you can't test it. You can't undertake universal testing, but you can certainly undertake sentinel testing. And we've got quite good sentinel testing systems. And we've also got very good data from people who donate blood as well, which is gives us good estimates of the R0 value and the prevalence of COVID within the kind of population. I think one of the issues that we started off with community testing, but then we stopped. This has been very controversial, and now we've restarted community testing again. And I'll come back to this a bit later on. And as Dr. Nihal sort of explained, obviously protecting the vulnerable is very important. So we had very strict shielding. We called it shielding measures. So we defined all the people that at risk in the whole country. They all got a letter saying that they couldn't, they had to stay in, they had to reduce contact, and we had to try and protect them. And we also took measures to protect institutional settings as well. The economic consequences have been absolutely terrible, and we could be looking at anything up to 14% reduction in GDP. And I'm not an economist, but people are saying it might take us 5 years to recover from this, and it's been it could lead to enormous job losses, etc. Well, it is leading to enormous job losses. And again, there's a whole series of economic measures that the government took, which have had this consequence. So if I can maybe say a few things about the kind of lessons learned then from my perspective, as I can say, this is my own personal kind of reflections on this. I don't necessarily reflect the sort of national government, and again, there's a lot of discussion about this at the moment, and people have got different kind of opinions, and also people now have got hindsight, and it's quite easy to make these observations with kind of hindsight. So I'm not being overtly critical. I'm just saying how I saw it. I think we could have been more open about it. I don't think we were open in terms of sharing information with the public, with sharing information within organizations. And I was quite surprised at that, because I think we're in the UK prides itself on quite an open kind of society, and we weren't. And I don't think we were sharing data enough, and we weren't sharing the. I think we could have been more open. I don't think we were sufficiently prepared for it. We had a run-in time. It was interesting to see Dr. Nihal saying that the initial response was poor in Sri Lanka. I think ours was also very poor. I don't think we took it as seriously as the government took it, as seriously as they could have done in February, March, and until we started seeing these pictures in Italy. It was then, I think that was a critical moment when everyone thought, oh my God, this is going to affect us, and we need to take action. So a series of actions were taken almost in panic measure. And I mean, there is an academic who's argued that we started the measures too late. And there's an argument that if we'd started 1 week earlier, the lockdown, we could have saved maybe half the deaths. It makes a very big difference in terms of the overall mortality as to when you introduce the economic and social measures. Like in any other country, where the main objective is not to overwhelm the health services. And I think that's one thing we did very well. On the whole, we created a lot more capacity. We created new hospitals to deal with this. And we stopped all non-essential healthcare. We run a national health system, and we were able to do that. And this is something I think we did quite well. And I estimated that I think in the end we only needed, we didn't need these new hospitals in the end. We only need, despite all the deaths that we've had, we only needed maybe a quarter of the overall capacity that was actually made available. So I think that was quite a success. But on the other hand, the negative side of that is we've I think we've probably suffered with having high rates of CVD, high, and maybe we haven't been treating as cancer as well as we could, and then knock-on consequences on people with non-COVID has been quite severe. Unfortunately, we weren't prepared with PPE, and this was a serious issue all the way through. We didn't have the right kinds of PPE. We didn't have enough of it. And unfortunately, we've seen a large number of deaths within the health and social care sector, certainly. And one of the big issues, certainly on the back of the Black Lives Matter, has been the very high number of doctors from the South Asian continent, particularly from India, Pakistan, and some from Sri Lanka, who've also been affected by PPE. And the mortality rate, particularly among the African, the Pakistani, and the Indian doctors, has been quite high. And that's a major issue, which is concerning the health system. Testing, we started off with community testing, but that was stopped. And that was stopped because we needed to do about 100,000 tests a day, and our capacity was 5,000. And it took quite a long time for us to get up to the 100,000 mark. And it wasn't until about end of April, beginning of May, when we had sufficient capacity. And by that time, we'd stopped community testing, which I think was a big mistake and had a kind of detrimental impact on us being able to control the epidemic. We have now introduced community testing again, which is really good. So we've got really good, strong and test and trace systems in place. The social consequences, on the whole, the response from the public has been pretty good. I think there have been issues with some of the Black Lives Matters protesting, and there have been some some social problems. But on the whole, people have taken it seriously. Perhaps the younger population perhaps don't take it as seriously as the older population. There's a big issue in terms of inequalities, and certainly, obesity is a major factor, and poverty is a major factor. Overcrowd in places where there's overcrowding, and you can see the mortality rates are much higher among the poorest populations, and that's a big issue. The Black and Asian minority ethnic staff has been a very big issue, and politically it's been taken quite seriously now. Care homes, I think care homes we've also struggled with. We've let down our elderly population. Initially, a lot of the focus was on the hospitals, getting the hospital system right, but unfortunately we didn't have enough attention to our elderly population in care homes, and there's been an estimate that maybe we've lost 20,000 people who we shouldn't have lost in terms of our approach towards care homes. Finally, just a comment about the economic measures, and it's becoming apparent now that maybe the economic measures that were introduced in March were kind of almost panic measures, and they were very wide. We didn't do that. We didn't do enough preparation during February and early March, and then we had to. The government had to kick into action very quickly and had to create a whole series of economic measures. So, for example, we introduced measures whereby people who couldn't work, the government paid 80% of their salaries, and there was a whole series of other support measures for different public and private sectors. Okay, I was gonna leave it at that, Chair, if that's okay, and then we can because it's such a big area and there are so many lessons to learn, and I thought we could have that discussion after we've had the experience from the USA as well. So, Chair, I was going to leave it at that, if that's okay.
Yeah, that's great, Prof. Zafar. So we'll be moving to the next presentation from the United States. That will be conducted by Dr. Naveed Pogasamy. He's from the Keck School of Medicine, Los Angeles, USA, California, USA. And currently he is an expert in infectious diseases with special interest in aspiration pneumonia and several positions in infectious diseases in multiple hospitals in the United States. So over to you, Dr. Navid.
All right. Hi, everyone. Thank you for having me here. It's a pleasure to speak to one of the most esteemed medical associations in the world. So it's my honor to be here, and thank you for having me. I'm excited to talk to you guys about the situation with SARS-CoV-2 in the United States. This is something that's been very prominent in sort of the practice that I've undertaken with infectious disease. And so we're seeing it obviously making a very steep impact at this point in time. So the sort of focus on my lecture is going to be on, or my overview is going to be on really the sort of disjointed response that we've had to it and sort of where that's stemming from, but also some of the strategies that we've undertaken. Just to give some brief important demography that's really impacted how we've responded to this. The United States is an extremely large country that is dispersed throughout a very large area. And you can see in this population density map that we have very large spaces that are rural and relatively underpopulated. And then we also have very large metro areas such as Los Angeles, where I live, and then also the northeastern seaboard, where we have up to 50 million people living along this stretch of coast here. Really briefly to sort of go through the timeline of how we've experienced this in the United States, January 20th is when we had our first case of SARS-CoV-2 and resulting in COVID illness in Washington state. And that was actually seen in a traveler who had come into the United States. And then we had a subsequent outbreak at a nursing care facility in Washington state as well after that. As far as subsequent actions, the real federal response came in early March, where we started having travel restrictions from Europe. And then there was a national discussion of what measures needed to be taken to actually curtail the spread, and then also to minimize and mitigate the damage that this sort of unprecedented pandemic was going to occur, or was going to cause. That being said, there were national mandates made to try to limit the gatherings of large groups of people, and then an initial recommendation for wearing face coverings coming in early April. Mind you, during this entire time, there was a very large discussion about the utility of testing and whom we should be testing and how those results should be managed. From a personal anecdotal experience, when I was working in different medicine units earlier in the year, our testing algorithm really evolved based on the data that was coming in from an international perspective. Because in early January and February, we were only screening people with the very limited number of tests that we had at that point in time based on travel history. So if they had recently traveled to Japan, China, or the northern part of Italy at that earlier point in the year. And I will also mention that we had a little bit of a snafu with our testing mechanisms and testing apparatuses early in the course of the pandemic, in the sense that the United States CDC, the Center for Disease Control, was tasked with providing us with our own reagents and our own tests, as opposed to the internationally available tests from the WHO. And it turns out that our initial tests were ineffective. And so that actually set back our public health response so far as having a approved test that we were able to actually use and implement broadly. One of the points that I've briefly made was that we started to limit gatherings and make shutdowns. And then by the end of May, we started to see all 50 states beginning to partially lift restrictions. And I'm going to talk about 2 states in particular. But where we find ourselves today is that the United States has been one of the most impacted countries in the world so far as the gross numbers are. You can see we just passed 4 million cases, and we've had over 140,000 deaths in the United States. You can see here in the bottom right-hand corner that our confirmed cases curve continues to elevate. There is a very significant concern in particular areas about overloading and overwhelming the healthcare system. And so what I want to talk about is really how our public health system is set up really to respond in a more local manner as opposed to having a national policy. And we've experienced a lot of similar issues, as the previous esteemed speakers from Sri Lanka and the UK also spoke about. We've experienced those similar issues as well. What I want to point up here is that in the left-hand corner here, we have a map showing the relative number of reported cases in the different states, being our second largest political entities outside of our national government. So we have our national government, and then we have our state-based political designations, where most of our public health responses are spearheaded from. You'll notice in this chart on the right-hand side of this slide, it's going to have a list of specific counties, which are going to be subdivisions of these individual states where we're seeing large numbers of cases. And so these counties all host major American cities. So Los Angeles County is the home of the city of Los Angeles. Cook County is where Chicago is present at. Maricopa County includes Phoenix. Miami-Dade is obviously Miami. Queens and Kings counties are New York City. And then Harris County is Houston, Texas. So we're seeing extremely large numbers of cases in the areas that were represented as dark red in that first population density map that I showed you. This density map is reflecting the rate of COVID. And so essentially, all of this dark red is when there's more than 500 cases per 100,000 people for this local county designation. So the lines you see on this map are for the individual counties. Keep in mind that large swaths of this part of the country here are rural with a relatively low population density. But I pointed out earlier that this eastern seaboard is one of the most densely and highly populated parts of the United States, with over 50 million people living in that area, particularly in the New York tri-state area. And I'm going to talk briefly about the experience in New York and also the experience in California, which I've experienced as both a physician and a private citizen. Los Angeles County is the area in which I have practiced internal medicine and infectious disease. And the reason I'm showing you this COVID-19 status report about the county is to make 2 points. One, most of our data is responded to at the county-wide level. As far as our public health infrastructure is concerned, each county typically has its own public health agency to which local or individual doctors and health practitioners will report to. What we're seeing in Los Angeles County in particular is that is a reflection of a couple different things. In the United States, we don't have a nationalized healthcare system outside of the Veterans Administration and the Indian Health Services for those specific populations, but rather we have a mixed public and private healthcare system. And LA County is very representative of those two. In the sense with the public healthcare system that we have in Los Angeles County, we have a system of 3 large volume level 1 trauma centers that are funded publicly and accessible to anybody regardless of their health insurance status. And health insurance is a fiduciary product that can be purchased to cover expenses that may be incurred when seeking healthcare. And so what you'll notice in Los Angeles County is that the majority of citizens derive their means to pay for healthcare from employer-based insurance, which has actually been how the country's healthcare system was set up after World War II. Many new jobs and whatnot recruited people not with salaries, but rather with what benefits they could offer. And one of those benefits included health insurance. You'll also notice that Los Angeles has a large proportion of people on what is known as Medicaid, which is our publicly funded and provided health insurance that is accessible to everybody. And there are sort of income markers that make one available for Medicaid, and then the government provides for your health care for these persons here. So part of the points that I want to make is that everybody is being affected regardless of their socioeconomic status. We've got the most cases of any county in the country in Los Angeles County, and we're an extremely ethnically diverse county, being approximately 50% Caucasian and 50% other. That being said, you can see the breakdown in these graphs here. We're also diverse with respect to age. And so we're seeing many people being affected by COVID, but our largest cohort that are testing positive are those between 35 and 64 years old. Based on the recent data that we have, it's this age group, including the 35 to 64 and also those 25 to 34, so this light blue and this large yellow block, this is actually what's driving our very high rate of cases at this point in time, coupled with an improved testing infrastructure. We've rebounded from that initial snafu with the poor reagents and are testing more people at this point and finding more cases. Anecdotally, what we're seeing, and what I'm seeing as a physician, we're seeing lots of mild cases, but we're still seeing patients that require mechanical ventilation and mechanical support for their respiratory system that are extremely difficult to wean from the ventilators. And so we're seeing extremely long hospital stays for patients who are requiring intubation. It's just extremely difficult to wean them from the ventilators. And that's actually leading to a very concerning situation in which we're starting to invoke some of our emergency plans to utilize other resources to help manage the large numbers of cases that we're having. That includes the US military. The US military is deploying physicians across the country to help with the ongoing surge that we're seeing right now. To talk briefly about the responses that we've seen in California in particular, which is something that I've experienced again as a private citizen and as a physician. California was relatively early to close down. March 15th, which was incidentally the start of a vacation I'd had for this year, the entire state shut down. We received messages through statewide messaging systems on our cell phones. We got text messages saying to please stay home. And we shut down March 15th and stay-at-home orders are put in place. You'll notice that we had a relatively lower number of cases at that point in time. I do want to give credit to the Johns Hopkins University very briefly because they've provided a wealth of interactive information that I would highly recommend taking a look at if you're so inclined. These red lines that you see on the graph represent individual actions taken to restrict the movement and attempt to curtail the spread of the disease. Green dashed lines are when there's a reopening occurring, and then blue dashed lines are when decisions are deferred to the county. So again, this is another example of a statewide public health agency deferring to local conditions and telling the local public health agencies, which are run by individual cities, to make decisions based on the data that they have. You'll also notice that towards the end of May is when we started to have a relative reopening. And then our cases in California continued to rise. And now we're in a series of shutting back down again. So between March and July, we had another reopening experiment where obviously we did not do a good job in maintaining social distance, mask wearing, and preventing the spread of disease by not engaging in close contact social activities. And we've continued to have a rise of cases in California. And this is to juxtapose to the experience in New York. New York actually coordinated with neighboring states in Connecticut, New Jersey, and in one point in time, Pennsylvania, to try to coordinate together as state entities to shut down and to mitigate the spread of the disease. You'll see that the numbers of cases peaked in New York at the beginning of April. And then at that point in time, with so many cases occurring, the governor signed orders to reallocate medically needed equipment because also like the UK, we also experienced shortages of PPE as well as necessary medical equipment to treat these patients. And so there was a diversion of resources from other states into the parts where it was hardest hit. New York was recruiting physicians from across the country to come to provide extra support to the staff that was there. New York eventually got to a point in time where they felt that they could do a gradual reopening as opposed to reopening everything en masse like we did in California. And so with their gradual reopening, they've had some success in minimizing the resurgence of COVID in those areas. And now they're discussing possibly reopening schools in the fall. To really point out again how our experience has been impacted by our governmental setup, our split between federal and state and local responses has really characterized the response in the United States. So we're seeing more state level wide responses. As far as our federal apparatus is concerned, we have the Center for Disease Control, which provides funding to most of these other public health agencies, being the statewide and the citywide level agencies. But we have a national limit on those powers by our federal constitution that makes it difficult for states, particularly, to prevent the spread of disease by limiting interstate travel. Individual states, such as my home state of Kentucky and Hawaii, put up individual rules limiting who could actually enter the state. But from a federal law perspective, those were not enforceable and thus unconstitutional. So for instance, Kentucky did not want anybody to be able to drive into the state from neighboring states, but there was no way for them to enforce that. And I knew people personally that had traveled in and out of the state. Kentucky itself is actually experiencing a resurgence of cases, and that's also been in response to people traveling from the state to vacation destinations in a hotspot of Florida and then returning to the state with cases. That being said, state and local agencies have a little bit more power because they can declare what's known as state of emergencies for their individual parts that allow them to halt business activities and social activities. For instance, during the height of our protests during the Black Lives Matter movement in the United States, the city of Los Angeles put out curfews at 5 p.m. where we were not allowed to be on the streets after 5 p.m. As far as the lessons learned, I too will just briefly speak on this because I think it's an interesting discussion point that we can all benefit from. But the United States has become keenly aware of the importance of widespread testing and tracing. We're still discussing about how many people actually need to be tested. We've been discouraging people with mild symptomatology from actually presenting to healthcare locales for risk of spreading it to other more at-risk persons. We've seen how important it is to fund public health apparatuses and securing supply lines for PPE. In my humble opinion, I think this is really the first time the United States has actually had to deal with a significant pandemic. And especially when we look at the SARS-CoV-1 outbreak in 2002 to 2003, the United States had approximately, I think, 90 to 100 cases. We didn't have a lot of cases, and so we didn't really retain a lot of institutional memory. From what I've seen in the international spectrum, South Korea in particular has been a really great role model for retaining institutional memory about previous pandemics. They had to deal with MERS and SARS-CoV-1, and that really informed their public health infrastructure and how their society valued government intervention for preventing the spread of disease. And I think that leads into the next point, that in the United States, we're currently dealing with a major issue of the politicization of the use of masks. We have a large contingent in society that doesn't believe that masks are effective or that they're just a mode of government control. And there's a large debate about if there is a need to wear it or if that infringes upon personal rights. And so we've not really seen something like this where medical advice has been politicized to this degree, even with vaccines. We're also seeing how it's going to be important to streamline federal responses to state and local levels. You may have seen conferences given by Drs. Fauci and Dr. Birx from the United States CDC, who are giving advice to individual states about how to manage this outbreak. And then finally, we're seeing that it's critically important to minimize economic damage to individual citizens, because like the UK, we're also expected to have a long road ahead of us so far as an economic recovery is concerned from all of the damage done by this pandemic. And so we have a National CARES Act that's providing subsidies to many individual citizens in the forms of economic stimulus, direct cash payments, and whatnot. So I do want to thank you guys for allowing me to speak and to be a part of this Congress, and I look forward to discussing this with you all further.
David, now we are privileged to have to welcome Professor TEO Yik Ying, who is also commonly known as YY. He is the second dean of the Swee Hock School of Public Health at the National University of Singapore. He is presently a member on the Council of Scientists for the International Human Frontier Science Program, as well as a governing board member of the Regional Center for Tropical Medicine and Public Health Network for Southeast Asia. Now, let us welcome Professor TEO Yik Ying to this SLMA session.
So thank you very much, and I'm very grateful for the invitation to be part of this momentous event. I believe that the previous speakers have spoken quite a bit about the situation across the world, and I think I would like to keep that short so I can focus a little bit more on some of the pertinent lessons that we've learned. Singapore, like many countries that we have heard about, actually experienced a painful lesson from SARS back in 2003. And that actually shaped quite a bit of our pandemic preparedness plans that has been tested in 2009 with H1N1 and now with COVID-19. And the situation in Singapore right now, we have between 100 to 200 cases every day that is being added to the count, but the majority of them actually come from migrant workers that are living in dormitories. And the situation in those settings allows the coronavirus to spread very quickly. In terms of the treatment, you would see from this chart that actually right now, there are no patients currently in intensive care units. And out of the 4,000 patients that are actively currently being infected, only less than 200 of them are actually within the hospital. The vast majority are being looked after in isolation facilities that are managed centrally by the government, but they're based in the community. And that allows the hospital resources to be kept for the patients that require it most, which will be the elderly and people with chronic conditions. This is the epidemiology chart of COVID outbreak in Singapore. And you could see that the outbreaks that Singapore are but essentially driven by importations. We have the first wave of importations in late January, and then we have a second wave of importations from North America and European countries between March and April. And this is when the situation, as we heard, affected both United Kingdom and the United States in quite a significant way from March onwards. And this is when there were a number of Singaporeans that are based in Europe as well as in North American countries. They returned to Singapore. Some of them carried the coronavirus with them, and that seeded community infections. Some of that community infections regrettably entered the migrant worker dormitories in April, and that has been driving the bulk of the outbreak in Singapore. If you look at the top panel, you would see that the majority of the outbreak are in shades of blue, and that signifies the people living in the dormitories, the migrant workers. So the strategy that Singapore has adopted actually varied depending on whether it is an importation case, whether it is a case from a migrant worker in the dormitory, or whether it is in the community. 3 different types of people have to be tackled differently. And I talk about the strategies. I think it's useful to realize that worldwide, what we learned about COVID-19 have evolved tremendously since it started in January. In terms of human-to-human transmission, right now, we know definitely it happened. But back in January, we were wondering whether it actually happened, humans to humans. The way that it's transmitted, whether asymptomatic spread can happen, transmissibility to pets and livestock, whether it is aerosolized or airborne. We have been seeing quite a lot of discussion about this in the past couple of weeks. Potential mutation, what kind of transmission can it be transmitted through food packaging, or when you're mailing or you're ordering something from America, from different parts of the world? Will you actually get a chance of being infected because of formite infections on top of the parcels? And even schools, there are a lot of unknown at present, and yet all of these unknowns have a direct impact to the kind of policies that countries adopt. And we know right now the settings that are best for transmission and for spread. Transmission is for one person to another person. Spread, it's more about the geographical distribution of the coronavirus to different segments in the society. And we know that this is where indoors, air conditioned, high human density, humans interacting for an extended period of time, engaging in activities where there are droplets, aerosolized of saliva and breaths, even events where you have different people from different parts of the society coming together. Those are events that are very suitable and transmissible for to allow the coronavirus to transmit. And this is the reason why countries are learning that nightclubs, pubs, clubs, discos, religious gatherings, religious congregations are still highly risky activities. And unless there are measures that can be put in place to minimize the risk of transmission in those settings, actually, the recommendation in many countries right now is actually still to place a limit or to restrict the level of engagement for some of these activities. Now, once you learn about the settings, and this is really where you start to decide in the society, what are the measures that need to be put in place at workplaces, in schools, in public spaces, public transportation that needs to be put in place. We saw that the greatest spread in Singapore was sometime in April. And that was when Singapore decided that we need to have a partial lockdown where the majority of workplaces were closed. People can work from home, they will resume working from home, but all schools were closed. Only essential services remain open. This was a period of about 8 weeks. And then we have 3 phases of opening. Right now, Singapore is in its second phase, but the second phase is likely to take a while before we move on to the third phase. Within the second phase, this is where eateries, schools, gyms are allowed to open. But I think one important point to highlight is that when we say that some of these public spaces are now allowed to open, there's actually a lot of measurements that have to be put in place. I will talk about the measurements in a bit, but let's look at what's happening in terms of tackling the risk of importations. The borders to Singapore currently still remain closed to short-term visitors. We have 2 green lane or travel bubbles that are currently being implemented. One is with China, the second is with Malaysia. But those are all for essential business travels. Mass market tourism is still not allowed. And in fact, the communications has been made very clear to the whole of Singapore that it is unlikely that mass market tourism out of Singapore to anywhere else in the world will resume by the end of the year. And I think that this communication sends a very clear message to the rest of the people within Singapore that the situation is still very dangerous. And we need to put in place the necessary precautions to minimize the importations of new cases. Any travelers coming into Singapore right now, perhaps they are returning Singaporeans, or perhaps they are essential business travelers, they have to be quarantined in a government facility for 14 days. If right now I choose to leave the country, not for essential business reasons, but just because I want to have my own freedom, I want to have my holiday, actually, the government allows us to do that. But there is a caveat. We will forfeit our rights to all health insurance if we leave Singapore during this period for tourism reasons rather than for business or essential business travel reasons. And that sends a clear message that you want to travel, you have to bear the risk to any implications. And I see this to be a very important message that is sent to the community. One thing about Singapore and the world has always been around schools. And there has been a lot of debate worldwide, including in the United Kingdom, including currently in the United States, around schools reopening. In Singapore, we reopened the school as early as phase one, which is in early June. But there were very strict measurements to make sure that in schools, children, teachers have a very little chance, a minimal chance of catching the coronavirus or being infected. Will the situation change in schools? Perhaps, and this is where policies have to evolve according to the situation in the respective country or in the respective region. But at the moment, the science tells us that children below the age of 12 has a much lower risk of infection, and even if infected, they have lower severity and lower risk of complications. But what we are starting to see worldwide is that older students, could be students in secondary school, in high schools, or in universities, they are just as liable and infectious if they catch the coronavirus. The issue with COVID-19 in schools is actually to do with children being infected and then bringing the infection back home to members in the family. Because when we look at the interaction patterns for university students, the university students tend to interact amongst themselves, but the second group that they are most likely to interact with will be adults in the age of between 40 to 60, typically the parents of those university children. And those are the groups that we are hoping to minimize infection because they will be at higher risk. I talk about the migrant workers, and right now the migrant workers are isolated in a stage of quarantine. But one very important aspect for the migrant workers is that they come to Singapore to contribute to the well-being, the development of the country. So during this period of quarantine, I'm pleased that at least the government is making sure that all the migrant workers continue to receive their salary supported by the government. All of them have a guaranteed complete health insurance if they are infected with COVID-19 in Singapore. The dormitories have now been restructured and there is some redesigning happening to minimize the risk of transmission within the dormitories. But the reality we know is that infrastructural developments, can only do so much to reduce the risk. So what happens is that we have to find a way to make sure that any of the migrant workers in the dormitories, if they are infected, if they're not feeling well, they have a very convenient way to a way that incentivizes them to report their health status. And so medical posts are now set up across all dormitories in Singapore. Connectivity in terms of Wi-Fi provision, food provision during this period of quarantine is guaranteed and made free of charge for all migrant workers as well. So the country is putting in quite a bit of effort to look after the migrant workers because we know that the setting they are in is highly infectious and we need to put in all the effort to make sure that we reduce the risk of spread within this group. If you return back to the epidemiology curve that I talked about, you will remember that the bulk of the transmission in Singapore is essentially driven by the migrant workers and not actually the people within the community. What about the workplaces? And I think we've heard a lot about learning about the coronavirus. And I think this is something that is very important as countries look towards easing their lockdown and allowing businesses, livelihoods to resume. There is a need for all settings, all workplace settings, all public spaces to have the necessary precautions, the safe management measures to be put in place. Is there a mandatory requirement for social distancing? Is there a mandatory requirement on mask wearing? How do you enforce? How do you monitor that actually this happens? So one thing that happens a lot in Singapore is that when you have laws, there is the accompanying monitoring as well as the enforcement as well. And as part of the enforcement, this is where there's a constant reminder that it is the individuals at the heart of it. That the reminder is always that if we can, we still minimize any unnecessary trips outdoors. And this is constantly reminded every day in the newspaper. The front page has a section that reminds the public what are the precautions, what are the steps and measures that individuals like you and me can take to minimize our risk. And that means minimizing any unnecessary trips outdoors, even for work, even for shopping and so on. If you have to go out, if you have to go out, the way that I phrase it really highlights that going out, it's an option that you choose as a secondary option. If you have to go out, practice social distancing, maintain strict personal hygiene, wear your mask. It is mandatory to wear your mask. It is mandatory to practice social distancing. And there is this safe entry check-ins and check-outs. It's a QR code. If I want to go grocery shopping right now, I have to scan the QR code. So during this time that I'm within the supermarket, they know that I'm physically there. So if there is an outbreak in the supermarket caused by someone who has been in the supermarket during that period as well, all of us will get a notice to say that we need to be careful, we need to monitor our health, perhaps we will be swabbed, or potentially we could be quarantined. There's this constant reminder, if you're not well, to see the doctor. This bit about not going to work or socializing if unwell really comes back to individual responsibility. And I think it's very important to say how much of this reliance on individual responsibility can happen in societies in East Asia, Southeast Asia, South Asia, Europe, and in America. There will be tremendous difference in culture and in acceptance to some of this personal responsibility. And when you have this reminder and this monitoring, it is all pointless if you do not enforce and there's no sanctions. In Singapore, there are a series of warnings, and if warnings still fail, if a person repeatedly refuses to wear a mask, repeatedly refuses to practice social distancing, they are fined, and if they are foreigners, they can be deported from Singapore. And there's a range. Right now, there are constant monitoring in terms of public spaces such as beaches. If you look at the right bottom corner, this is hot off the press, yesterday's news. Beaches in Singapore crowded, and therefore they have officers monitoring the density of people and shutting down, minimizing further entry until the crowd disperse a bit. And I think these are all the measures that are necessary to make sure that restrictions can be lifted in a safe manner while reducing the spread. And I think the final bit is really making use of science and evidence to decide how to manage the outbreak. Quite a lot of countries at present still actually decant people with mild infection back home. To be managed at home, you tell the person you have COVID-19, but since you're young, you're unlikely to be in the risk group. Manage your disease back home, try to minimize people meeting other people. That, in my opinion, is a recipe for community transmission to take off. There is a need to set up field hospitals, so even the mild cases are managed in the field hospitals. The tertiary hospitals are reserved for those with a much higher risk of complications and of deaths. But the mild cases, the young people, they can be managed in field hospitals with some clinical surveillance, but not a lot of medical equipment necessary. So I thought I would end off by highlighting some of these lessons, because our approach in Singapore has been very much focused on the outcomes. And what are the outcomes that matters? It is not having 0 cases when the country is in a lockdown period. It doesn't count. If you have 0 cases when the country is undergoing a very strict lockdown, it gives the sense of false confidence that, oh, the situation is under control. And then when you lift the lockdown without putting in place suitable and prudent measures, the infection comes back and it takes hold within the country again. And this is really why our previous speakers, resource people, have constantly highlighted the same principle around testing, contact tracing, the ability to isolate and quarantine people quickly. It is not about the infection numbers. It is all about minimizing complications and deaths of people that are infected. It is about protecting your healthcare workers. How many countries have actually seen widespread infections amongst the healthcare workers? And I see that as a tremendous failure of health system if they are not able to protect the healthcare workers to provide them with the necessary equipment for them to go about their work in a safe manner. The universal health coverage, the financial protection, the financial safety nets for people who are infected is this incentive if individuals have to cough out 50,000 in excess to 100,000 just for treatment of COVID-19. I think we have heard our speakers from UK talk about fiscal support for individuals and businesses. Equally, countries need to realize that the impact of COVID-19 goes beyond health, but it tremendously affects the economy. And if people are struggling to make their living, to earn their wages, especially in many settings in the world, particularly in Asia, they rely on daily or weekly wages. Trying to shut down the economy for 8 weeks means that there will be tremendous hardship, widespread poverty, and widespread hunger. And that can alone create just as large an impact to the health of people as COVID-19. And then there are issues around protecting vulnerable and neglected populations. But I think this is where we all realize that in a situation like COVID-19 that is highly transmissible, the region, the country, the world is not safe until the least protected group is looked after. And if we do not take a transparent lens to look at which are the most vulnerable sectors in the society and to put in place the necessary safety nets to look after them, I think the community as well as the country will continue to struggle with the COVID-19 situation. With that, thank you very much again for the opportunity to speak, and I look forward to the discussion. Back to you, Professor Indika.
Thank you, Wai, for a very informative overview of the Singapore situation and the comparison. Now, we have a little bit time left for discussion. There are some questions coming from the participants who are joining online as messages which are sent to the resource persons. In addition, there's one question from the resource persons here, Dr. Abeysinghe. From Dr. Abeysinghe, the other question is that is there a possibility of closing down the urban areas like schools and business and make it online and leave the rural areas? That's one question that was coming from the audience, from the participants.
So the question is that whether it is possible to close down, is it?
Yeah, close down in the urban areas, especially the schools and the businesses, and make it online, and then leave the rural areas open.
I think it's not possible in this country because the facilities that are available even within the urban areas for the marginalized populations and the low-income population. So it's really not possible in this country.
Okay. Yeah, please.
All right. We have here a question from Anuradhika Ratnayake for Professor Dr. Navid for Gasimi.
It's responded. It's responded. Yeah, that was responded. That question was that was responded in the online platform. The question was, now it seems that the United States, it works like 50 states separately. I mean, each state working like a separate country. And when analyzing data, when you present the whole country data as United States, that might be misleading. So that was the comment. So Dr. Navid, do you want to comment on that again, very briefly? Sounds are not coming.
Response that I wanted to put into the text at least was that the way the national public health apparatus in the United States actually aggregates data is from a regional perspective. I believe there's 9 regions that we collect data from. And I think that would be a better way of communicating our data, because these aggregated regions are more demographically and then logistically similar in the sense that you have the same sort of supply lines, food systems, et cetera, et cetera. And so you see more commonalities amongst those regions as opposed throughout the entire country itself. I don't know if this is necessarily adaptable to every large country in the world, but I think it was something that would work for us, and it would misconstrue our data to a lesser degree, because we're really seeing the cities in the United States being hard hit at this point in time, as opposed to the rural regions.
Okay, the next question is for Professor YY from Dr. Anuradhika. Trade and tourism, which requires in-person traveling, plays a huge role in the economy of Singapore. How has Singapore as a country faced this challenge in COVID-19 situation in balancing economic policy and health policy of the country?
Thank you very much for the question, and fantastic question. And I think the answer to that is it's not just Singapore that has this reliance on globalization, on tourism, and on business travel. In fact, a lot of business developments in Singapore actually rely on people coming into Singapore and Singaporeans going out to other parts of the world to do the business. The reality is that importations will remain the largest and the most significant risk for COVID-19 to every country. And if we allow travel in any form, business or tourism, without the necessary precautions, and I can talk about some of the precautions that can be taken, but if unrestricted travel is now allowed, it is almost guaranteed that there will be further spread within a country as a result of travelers coming into the country, bringing the infection in. So Singapore government understands that risk very well. And because of that, regrettably, that remains a sector that has to be closed. We are exploring very closely what are the possible green lane arrangements with other countries, including other parts of Southeast Asia, including other parts of Asia Pacific. But even for some of this green lane arrangement, there are very strict conditions that are put in place. Pre-departure testing, post-arrival testing, there's a period of quarantine of between 24 to 48 hours until the test results are available. There is a fixed itinerary that individuals have to follow on. In summary, business-related travel comes with its own requirements as well. And I would say that is a second best solution. But the current solution is still, it's not allowed. But what does that mean then? Because by restricting one sector, such as the tourism, the travels-related sector, that reduces the risk of coronavirus spreading within the country. And that alone allows other sectors within the economy, within the country, to resume. So it is a balance, it is a compromise. You have to decide which are the high-risk industries, which are the high-risk sectors in the society that we have to shut down, and it potentially have to remain shut for quite a long while until there is a viable solution, perhaps in the form of a vaccine. But by doing that, you allow the other sectors in the economy, the small and medium enterprises, the schools, to resume. And that actually is a balance and a compromise that societies will have to reach eventually. And it is not easy because it will increase what we often talk about, inequity in life. Because how do you tell someone that I have to take away your job, I have to take away your livelihood so that this other 10 people can continue to have their jobs and to continue to make a living for their family? Social cohesion will be tested during this period as a result of some of this seemingly inequitable policies. But it's the kind of conversations that government policymakers need to be having with the people very transparently and very frankly to say that we can allow certain sectors to resume with the safe management measures, but there will be certain sectors, perhaps the nightclub, the nightlife industry, the travel-related industry will have to remain shut for a much longer time. And as the government, I put in place the safety nets to help some of the people that are employed in this sector. But the rest of the economy can resume. And I hope that would be a useful guide to some of the challenges and decision making that Singapore has gone through in the past 4 to 6 months. Back to you, Chair.
Thank you, Wai. My co-chair, Dr. Olivia, you want to make any remarks?
We are now wrapping up this session.
You can make a remark.
All
and
right,
then,
yeah. So yeah, I would just like to reiterate what our speakers have told about this evolving pandemic. So as we actually move forward, and this is not going to end soon, we also tailor our public health measures, our interventions, and it's really a very good opportunity to learn from USA, from UK, from Singapore, and of course our very own here expert, Dr. Nihal from Sri Lanka. And as WHO, we continue to support the world, the Sri Lankans as well, in terms of providing guidance, providing evidence and guidelines. And as I would like to echo what our DG Tedros has said about solidarity, science, and finding solutions. And SLMA is doing a good job of providing us the evidence and the data so that we can tailor and make our interventions fit for the context that we are in. Thank you.
Thank you very much. And with that, we come to the end of this very important, very useful symposium where we shared the experience and lessons learned worldwide. And I thank all our resource persons, our own resource person, Dr. Nihal Abeysinghe, and Professor Zafar Iqbal from UK, and Professor YY, my good friend, and very especially Professor Naveed and also Professor Elahe, who joined from USA at the, I think, very early morning for you. So thank you, everyone, and I thank all the audience, and there were a lot of others joining online, several from different parts of the country as well. So thank you, everyone, and have a good time. Thank you.